So welcome everyone to the January 21st, actually I guess it's the 22nd, January 22nd, 2021 edition of UW Nephrology Grand Rounds. We've got a special Grand Rounds today. So during the entirety of the first hour from 8 a.m. to 9 a.m., multiple UW faculty panelists, both from within the nephrology division and from without, will be contributing to an interdisciplinary rapid fire presentation forum on the subject of the use of SGLT2 inhibitors in clinical practice, followed by a 30-minute discussion forum, kind of open to all. Following the forum, our own Dr. Chris Blosser will be giving a talk at 9 a.m. on cancer immunotherapy for kidney transplant patients. So I wanted to just give a brief introduction to the SGLT2 inhibitor forum before I hand it over to our speakers. I first wanted to thank Ian DeBoer and Caroline Pitney, both of whom are on our speaker panel today, who encouraged me to set this up. I think as just brief background, we all know that there has been and continues to be growing use of SGLT2 inhibitors in clinical practice. In the kidney disease world in particular, we're obviously increasingly using these agents for the prevention not only of adverse cardiovascular outcomes in our patients, but also the prevention of adverse kidney outcomes. And as we'll see, many other specialties as well as primary care providers are also increasingly using these agents, considering their use or dealing with the effects of their use. And since SGLT2 inhibitor use and prescriptions span multiple medical specialties, we thought it'd be important to hear not only from nephrology on this topic, but also individuals representing endocrinology, cardiology, primary care, and clinical pharmacy. So I'm grateful for all the speakers for being here this morning. I'll introduce them more fully before their respective 5-minute presentations. But briefly, they're Ian DeBoer from our division, Dr. Earl Hirsch from endocrinology, Dr. Alec Moorman from cardiology, Dr. Chris Wong from general internal medicine, and Dr. Caroline Pitney from clinical pharmacy. So following their presentations, we'll have a discussion forum. So I encourage you all to write down your questions or topics for discussion. Also feel free to write in the chat, which I'll be moderating, or using the raise your hand function in Zoom. We'll wait for all questions until all 5 of the speakers have presented. So without further ado, I wanted to first introduce Dr. Ian DeBoer. And Ian, you're welcome to share your screen while I introduce you. So of course, Dr. DeBoer needs no introduction to most of us, but as I know, we do have some guests here today. So he's professor of medicine in the Division of Nephrology here at UW, practices clinically at the VA, is an international expert on the intersection of kidney disease and diabetes. Perhaps most pertinently here today, he was the co-chair of the KDIGO work group that put together the recently published KDIGO 2020 Clinical Practice Guideline for Diabetes Management in CKD. So welcome, Ian, and take us away.
Thanks, Matt, for the introduction and for putting together this forum that I've been very much looking forward to. And thanks in advance also to all the guests from outside the Division of Nephrology. I think it's exciting to have this cross-disciplinary talk. I'll be pretty quick. I'm presenting the nephrology perspective here, but there are at least 50 other nephrologists in this meeting who have this perspective, and I hope that they'll share their thoughts during the forum as well. But just to lay some groundwork, we do now have 10 large outcome studies of SGLT2 inhibitors versus placebo. 4 of them are cardiovascular outcomes trials. 3 of them are in chronic kidney disease populations and 3 in heart failure populations. And they demonstrate impressive effects. And I'm not going to belabor these. These are the estimates of effects from meta-analyses of 5 of the early studies, reductions in atherosclerotic events by 10%. Recall that these initial studies were done for cardiovascular safety using this outcome, which was significantly improved. Cardiovascular death reductions by 15%. And then larger magnitudes of effect for heart failure and CKD progression, which seem to be the 2 outcomes that are most largely affected by these drugs. And for all of these drugs, or all these outcomes, there appear to be class effects. In our field, we're particularly interested in the kidney effects, and not only our kidney disease progression, not only is that one of the outcomes that's most strongly reduced by 30% in credence and by 39% in DAPA-CKD, but we also have these two trials as well as SCORED, which was published last week for sotagliflozin, specifically in CKD populations. So directly addressing our patients, at least our proteinuric patients with type 2 diabetes, showing that there's efficacy for CKD progression and cardiovascular outcomes in CKD patients. And then with DAPA-CKD in particular, of course, there was a third of the population that did not have type 2 diabetes. And while the numbers of events and incidence rates were lower in that subset of DAPA-CKD, the relative risk reduction for CKD progression was at least as favorable as for those with type 2 diabetes. And that's also been seen, as we might hear from Dr. Moorman, in two of the heart failure trials, that the effects are similar in people without type 2 diabetes, making us hope as a nephrology community that these are drugs that we'll be able to apply beyond type 2 diabetes to proteinuric non-diabetic kidney disease sometime in the near future. And Matt referenced the KDIGO guidelines. And these have elevated SGLT2 inhibitors to first-line therapy along with metformin for people who have type 2 diabetes and CKD. And the guideline suggests that this is appropriate for people with any flavor of CKD. So that could be persistent albuminuria with normal kidney function, proteinuric patients with declining GFR, or even non-albuminuric CKD with eGFRs in the 30 to 59 range. And based on the evidence I presented, I do believe there's strong indication that we should be implementing SGLT2 inhibitors broadly in this population. And the KDIGO guidelines do provide some guidance on how to do this. There's increasing questions about this threshold of 30 mils per minute. I think there's clear evidence that we can start down to an eGFR of 30. This might come up in the discussion. What about lower levels? And there are now 3 or I think 4 trials that have used lower eGFR thresholds, and that might be pushed down in the near future. There are implementation issues to consider. Who should we prioritize? Who might have potential contraindications? How do we do this as nephrologists? Sophia Zongas and I have this How I Treat figure in press at CJASN that tries to deal with some of the implementation issues, including how to implement a sick day protocol to reduce risk of diabetic ketoacidosis. What sort of follow-up do you need and anticipate? And then how do you prescribe SGLT2 inhibitors if you're worried about interactions with other hypoglycemic drugs and exacerbating hypoglycemia, or diuretics and precipitating volume depletion? And in general, I just want to comment that I think the hypoglycemia and volume depletion risks are low with SGLT2 inhibitors, though there probably are subsets of patients who are at high risk for whom we need to pay more attention, and in particular, make sure that we follow up. So when I thought about some of the questions from the nephrology perspective that we have about SGLT2 inhibitors, these are the ones that come to mind to me. First of all, should we be proactively and systematically seeking out patients with type 2 and CKD? Right now, I prescribe these to my patients when I see them in clinic, but there are lots of patients at the VA who are not coming to my clinic or my colleagues' clinics. Who should prescribe these drugs? What communication is needed between providers when they're started, and does it vary based on their characteristics and who's seeing them? When and how should we worry about concomitant medications? What do we need to do for monitoring and follow-up? And should and when should we extend to other populations, including non-diabetic CKD, kidney transplant patients, which are currently not included in the KDIGO guideline recommendation, lower eGFRs, dialysis patients, type 1 diabetes, and then what about combining SGLT2 inhibitors with other drugs like GLP-1 receptor agonists or alternative medications? So that's all I have, Matt, for the time being.
Thank you so much, Dr. DeBoer. we will, without further ado, move on. So Dr. Hirsch, you're welcome to share your slides. So I wanted to introduce Dr. Earl Hirsch, who is the UW Diabetes Treatment and Teaching Endowed Chair in the Division of Metabolism, Endocrinology, and Nutrition. He is obviously an international expert on the management of diabetes and has been involved in numerous major clinical research trials with more acronyms than I can manage here. Has been honored countless times for his clinical work, teaching, and research. So welcome, Dr. Hirsch. And you'll need to unmute yourself, Dr. Hirsch. Earl, you're muted.
Unmute. Okay, can you hear me now?
Yeah, perfect.
Okay, let's put this up. Can you see the slides?
Yes.
Okay, wow, okay. So I was asked to talk about the endocrinology perspective of the SGLT2 inhibitors, and Matt and Ian, thank you very much for inviting me to this discussion. So let's go down the checklist from an endocrinology point of view. Do these reduce blood glucose? The answer is yes. If you go to the pivotal trials, they're 0.7 to 0.9% in A1C. I would take a little bit of a disagreement with my very good friend and colleague, Dr. Boer, because when you are using these drugs with normal renal function, they obviously work better because you have more glycosuria. And so hypoglycemia does become more of an issue in somebody with an eGFR of 80 than somebody at 35. We do see a little bit of weight loss, not as much as with the GLP-1s, and we do have the renal benefit you just heard, and you'll hear from Dr. Moorman more about the cardiac benefit. So these are great. So what is the problem? And there is a problem here. There are some concerns as an endocrinologist that I have. Number one, everybody knows about the mycotic infections, especially we see in women. And then, of course, I was in DKA and all I got was this lousy t-shirt. We do see quite a bit of DKA, especially in type 2 patients around surgery, stopping insulin, type 1 diabetes, which is a very important issue, as we are sometimes using these in type 1s, illness, low-carb diet, pancreatitis, and dehydration. And the DKA is very real. In fact, in the sotagliflozin study that was released and published last week in the New England Journal of Medicine, there was twice as much DKA with the sotagliflozin group than in the placebo group. So this was a patient that came to me last February. I've actually been seeing him for many years. He's 81, A1C of 8.2. He only takes insulin. And I actually took care of his daughter who had type 1 diabetes. And the day before his visit, a non-UW cardiologist who did not have the ability of Epic to share notes with me, he prescribed empagliflozin, and it was reasonable with his cardiac history. But the problem is this 81-year-old man with an A1C of 8.2% has type 1 diabetes. The cardiologist started the drug in this man with type 1 diabetes, where the drug actually would be off-label. The other problem is lack of communication between providers. Was the cardiologist now going to adjust the insulin with this patient's continuous glucose monitoring? The drug was prescribed the day before, was never picked up from the pharmacy, so the patient never took it. But this was what I would call a near miss. The third problem is, who's going to be the bartender for the prescription? And who's going to take care of the adverse events and the glycemia when they occur in this gentleman with type 1 diabetes? So the issue of who is the bartender is a common concern of mine. And it's my opinion that when a primary care provider, endocrinologist, nephrologist, or cardiologist are all involved with the care of a patient who could have more than one reason to use these agents, there needs to be communication. Who is writing the prescription, who's changing the diabetes medications, and who's in charge of the side effects. Because right now, I don't see that happening as often as it should. The American Diabetes Association guidelines is still metformin is first, but if somebody has a high risk or established atherosclerotic coronary cardiovascular disease, CKD, or heart failure, we are going to start with an SGLT2 inhibitor or a GLP-1 receptor agonist. And the quote is, in patients with established atherosclerotic cardiovascular disease or high ASCVD risk, heart failure, or CKD, an SGLT2 inhibitor or GLP-1 receptor agonist with demonstrated CVD or renal benefit are recommended. And here's the important point of the sentence: independent of A1C. Independent of A1C. It's not an A1C glycemic centered recommendation as we have seen from the ADA traditionally. And then the European Society of Cardiology with EASD took it one step further. They think these drugs should be first line and just forget metformin. And that recommendation came out a couple of years ago. So are the appropriate patients using SGLT2 inhibitors, and who is writing the prescription? Now, this paper was published just a few months ago, but it comes from 2018. And there were 90,000 people with type 2 diabetes prescribed this. But by the end of 2018, 12.2% of those with cardiovascular disease or heart failure received the drug. So we're somewhere in the COVID vaccine vicinity in terms of prescribing. And it's interesting who's doing the prescribing. Only 3.6% was cardiology, almost 19% was endocrinology, but remember, there aren't many of us. Nephrology was somewhere in this large group of internal medicine docs. I don't know how much was nephrology, they didn't break it out, but you can see it's quite interesting who is prescribing the SGLT2 inhibitors. So finally, I want to point out, if you look at primary care providers, and those counties without are white, those counties with are blue, you can see that if we even look at Alaska and Hawaii, most of the country has a primary care provider to provide diabetes care, to provide CKD care, and to prescribe SGLT2 inhibitors. But what about people like myself? What do we know? This is what we know. This is not the political map from the last election. This is every county in the United States with either an adult or pediatric endocrinologist. Not a surprise, we are not able to even fill our fellowship positions at a national level. So this is not going to be our problem. This is actually an issue that I think primary care, people like Chris and Ian and Alec are going to have to deal with, because for most of the country, there are not people like me to help. So I would conclude that the SGLT2 inhibitors result in just sort of an average A1C reduction, mild weight loss, but result in frequent genital mycotic infections in women and infrequent euglycemic DKA, although risks for this can be mitigated. And this is a huge interest of mine, including the mechanism of the DKA. I should also point out that the issue with the amputations, that concern, the FDA took it away from canagliflozin last September. They went back over more and more data. The amputations are now not a concern. We need more communication with each other about appropriate use of these agents for individual patients and who will address the diabetes medication changes, whether insulin or sulfonylureas, and side effects when they occur. Given the cardiovascular and renal data, these agents are underutilized and should be used earlier in the treatment algorithms for type 2 diabetes, and we are already seeing that. And then we need to point out that to the payers, these agents are simply expensive glucose-lowering drugs, and that is a huge concern of mine. The cardiovascular and renal benefits are not considered when we talk to all of the payers about who's going to get this drug. So with that, I thank you all for your attention.
Thank you so much, Dr. Hirsch. Really appreciate it. Without further ado, I will introduce our next panelist, Dr. Moorman. So Dr. Moorman is UW Associate Professor of Medicine, Division of Cardiology, Section Chief for General Cardiology at UW Medical Center. Board certified in echocardiography, cardiovascular disease, and internal medicine, has been involved in the international ischemia and ischemia CKD trials, and also works closely, as you all know, with our transplant colleagues. So welcome, Dr. Moorman.
Great. Thank you so much for having me. It's an honor to be here as the cardiovascular representative for the group. Can you all hear me okay?
Yes.
All right. Well, let's get started here. So first, I wanted to briefly review the mechanism of why SGLT2 inhibitors have these really amazing cardiovascular benefits, and predominantly a heart failure benefit that is seen. So most in the room may already know this, but as you know, SGLT2 inhibitors promote glucosuria, but also natriuresis. So that's helping preload for our patients with heart failure. There's also evidence that these drugs improve vascular function and lower blood pressure, which reduces afterload, another hemodynamic benefit. But beyond the hemodynamic benefits of these drugs, they seem to improve myocardial energetics, and there's theories about why that may help the heart shift to a more efficient metabolism that's healthier. They impact cytokines and adipokines in a way that is beneficial. And lastly, they may reduce fibrosis and necrosis in the heart muscle. So as we've seen, the story started with the EMPA-REG and CANVAS trials, which were diabetes trials, but showed a profound reduction in cardiovascular death and heart failure hospitalization, and even all-cause death. What was interesting is that these drugs, when you look in these trials, the MI rates were similar, so the benefit was not being mediated by a reduction in atherothrombosis. And in these early diabetes trials, only approximately 10% of the patients were identified as having heart failure when they were enrolled in the trial. So Dr. Boer already presented some of this data from the meta-analysis from JAMA Cardiology last year, but I just wanted to highlight on the left, when you look at the heart failure hospitalization reduction, it's very consistent across the trials. And that's true when you look at all the patients, and also when you divide the patients up by whether or not they were diagnosed with atherosclerotic vascular disease. Conversely, the reduction in the standard MACE endpoint of myocardial infarction, stroke, or cardiovascular death was more modest. And when you looked at the patients who did not have ASCVD at enrollment, that benefit was questionable. So it's really a heart failure drug, and it's within the diabetes guidelines. As Dr. Hirsch pointed out, we still think of metformin as the first-line therapy, but they point you down this path that if your patient has established atherosclerotic vascular disease, or CKD, you should think about SGLT2 inhibitors as your first-line next option if the patient has a heart failure phenotype that predominates. Now, what about patients who don't have diabetes? Because of the heart failure benefit, dedicated heart failure trials were conducted to see if these drugs were beneficial for patients with heart failure who did not have diabetes. So the first was DAPA-HF, which was a trial of patients with an ejection fraction less than 40%. And almost 60% of the patients in this trial did not have diabetes, 40% did. And about 27% of the patients were on insulin. And what was seen was a 26% relative risk reduction in the primary composite endpoint of heart failure hospitalization or cardiovascular death. And when you looked at the patients with or without diabetes, the benefit was similar. And importantly, there was no real difference in incidence of volume depletion, renal dysfunction, or hypoglycemia within this trial. So beneficial and safe. EMPER-HF was the next trial, which was empagliflozin in patients with an ejection fraction less than 40%. Very similar trial to DAPA-HF, about 50% of the patients with diabetes and 50% without, and a very consistent outcome with a 25% reduction in the composite endpoint of heart failure hospitalization or cardiovascular death. It was also shown that the GFR decline was slower in the patients who were treated with empagliflozin. There were more GU infections, but there was no difference in hypoglycemia or amputation. So this slide, I just wanted to show everybody where SGLT2 inhibitors sit in the kind of orbit of what we call guideline-directed medical therapy for patients with heart failure. So these are, the dots represent heart failure trials, heart failure with reduced ejection fraction. And on the y-axis, you have the relative risk reduction in all-cause mortality. And on the x-axis, you have the all-cause mortality, the annual mortality rate seen in the placebo or the control arm. And up here, the blue dots are our heart failure trials, our beta blocker trials. You see the SGLT2 inhibitor trials, DAPHF and EMPEROR, which are circled in red, are in the same orbit as what we see with Entresto and what we see with enalapril. And because of that, these drugs are now considered part of guideline-directed medical therapy for all patients with systolic heart failure. And these are the brand new heart failure guidelines, which show us that patients with systolic heart failure should be treated with either Entresto, which is or an ARNI, an ACE inhibitor, an evidence-based beta blocker, diuretic therapy to decongest, an aldosterone antagonist such as eplerenone or aldactone, and then SGLT2 inhibitors now are considered guideline-directed medical therapy for all our patients with systolic heart failure. So I'll close with my conclusions on our questions. So first, SGLT2 inhibitors should be considered for all patients with diabetes, with type 2 diabetes and who are at risk of heart failure. They're now considered part of guideline-directed medical therapy for patients with HFrEF, whether or not they have diabetes. But the question is, should cardiologists be prescribing these drugs? I have the same questions and concerns as Earl and Ian. So I think, yes, cardiologists should be considering prescribing these drugs. And the reason I say that is I see a lot of therapeutic inertia where when I see a patient as a consultant and I recommend that the SGLT2 inhibitor be considered, when that patient comes back, I frequently find that it has not been started by their primary care doctor. So I think we need to do this, but we need to do it safely. The anecdote that Earl told is the patient that scares me. I don't want to mess up and start this medication on somebody and give them euglycemic diabetic ketoacidosis or some other terrible adverse reaction. So I agree, we all have to be in communication with each other when we're considering these drugs. And then I'm also hoping we can focus our discussion today on how we get these medications for our patients. They're of course expensive. And as Earl pointed out, the payers always seem slow to recognize the clear benefits we see for our patients. And there's a hesitancy there for these drugs to be covered. And then lastly, I apologize. I was buried in the CCU last week when the sotagliflozin trial was published, so I have not reviewed it closely, but this is an interesting drug because it's a combined SGLT2 and SGLT1 inhibitor. And this drug not only reduced heart failure outcomes, but also had a more pronounced reduction in MACE compared to the other trials. So that was presented at AHA in November, but I haven't gone through the publication yet. And that's what I've got.
Thank you so much, Dr. Moorman. Appreciate your perspective. Our next panelist is Dr. Chris Wong. So Dr. Wong is UW Associate Professor of Medicine in the Division of General Internal Medicine. He practices general internal medicine at the Roosevelt Clinic. He has an extensive clinical practice, is heavily involved in house staff teaching. We're lucky to have him here today. So Dr. Wong, go ahead. You may have to.
Okay, can you guys hear me okay? And can you see the slides?
Yep, it's perfect.
Great, thank you so much for inviting me. This is an honor. I'm not on any national committees or doing any international research trials, so, but it's perhaps representative of the primary care doc in the audience. So first caveat, obviously this is my perspective. Let me just make sure this advances. And I'm only talking about type 2 for good reasons, as I think Earl astutely pointed out. I just want to talk a little bit about the evolution of what I've seen in the primary care clinic, at least in our clinic. Initially, really, we thought of this as a diabetes drug, and as you've heard, this is more than just that. We had a lot of interest because it's oral. Don't have a lot of great oral options, but a lot of the cautions really made us not prescribe it. So Earl put up that slide of 2018 primary care docs prescribing. That was not us in our clinic. We probably were much lower than that. And then the side effects seemed so bad, potentially, especially with amputation and DKA and with unknown mechanisms, that it really made us cautious. Those of you who have trained as long as I have remember the glitazones. like troglitazone in the late 90s, rosiglitazone in the early 2000s being taken off the market. So feeling a bit burned by drugs that maybe didn't have great data or had side effect issues that we worried about. And ultimately, in the early days, it didn't matter because no one covered it. So we could never get it anyway. Then, as you've heard, the data, which I won't summarize, the last few years, lots of perspective saying, well, maybe this is not really a diabetes drug. Maybe it's mainly a cardiovascular drug and it happens to lower blood sugars a little bit along the way, or it's a chronic kidney disease drug, et cetera. So a lot of increased interest in different indications, I would say. Still cautions about the side effects. And at least, what I had seen is empagliflozin didn't seem to have the amputation risk in the trials. And it's nice to hear that Earl mentioned about canagliflozin not having that as well in terms of the FDA release, although that was the one where that signal really showed up. Also getting some at least quantitation of the DKA risk. It looks to me like roughly 1 in 1,000, but at least trying to get a sense, is this like 1 in a million and 1 in 100? How much do we have to worry about it? And then getting a sense that we can deal with the GU infections, 4NAs accepted, we can just deal with the rest of them. And then there's been some concern about bladder cancer. So still some concerns, but increased interest in the indications and then slightly more coverage. And so where are we now, at least in our clinic? Well, we're still kind of considering it a diabetes drug, but I call it a diabetes plus drug. So it's diabetes and cardiovascular and chronic kidney disease drug and heart failure. We tend to be pretty conservative as a group, and I don't mean politically, I mean in terms of new drugs. And so we are kind of sticking with the FDA indications. And as Alec pointed out, that could be therapeutic inertia in a good way, could be therapeutic inertia in a bad way. Still some concern about those side effects. And the good news is I'm seeing a lot more real world coverage in my patients. So I have a lot more ability to prescribe this than I did, say, 5 years ago. So that's actually really, I think, good news. Still concerned about side effects, but, and this is just my take, not necessarily the guidelines take, but a lot of the other drugs have a lot of downsides too. And so seeing the outcome data from the SGLT2s, to me, outweighs a lot of the other issues. And this is just my kind of crude look at this. But SGLT2 on the right, other drugs on the left. But for example, sulfonylureas, DPP4s, they have glycemic data, but their cardiovascular, microvascular, other outcome data, it's really not there. So to me, the biggest rival for the SGLT2 are the GLP-1s. And I tend to favor the GLP-1s. I give them an edge over SGLT2s because of that and a better side effect profile. And then insulin, I give it the edge because I'm weighing a little bit more on the macrovascular, but obviously insulin has very good microvascular data also. So bottom line is all the diabetes drugs have some drawbacks, but these clinical outcomes and the ease of use are really, for us, pushing them a bit, the SGLT2s a bit higher. So this is not, big warning, this is not what the guideline shows, but this is how I kind of think of it in the real world these days. Metformin for everyone to start with, and I agree it's debatable whether that still should be the first line, but let's just start there. I tend to go GLP-1 if the patient can tolerate injections and they have insurance coverage for it. And if you still need control, then we're thinking maybe adding SGLT or going to insulin. And then the other pathway now is really metformin and then right to SGLT2, again, because we have better insurance coverage than we used to. Can the patient accept some of these side effects? And again, talking to a patient about risk of DKA to a patient with type 2 who has no idea what DKA is it's a really hard shared decision-making conversation. And then if we still need more control, however you define your target of control, you could add GLP-1 or maybe go to insulin. And then all primary care doctors have this pathway. I call it the PO pathway, which is they will not accept any injections. And then you're talking maybe doing the DPP4s. If you're really lucky and you can get oral semaglutide, that's fabulous, but most people can't get that. And I'm kind of avoiding sulfonylureas completely now. And I didn't put the thiazolidinediones, honestly, because very few of us start those drugs anymore. So this is kind of a crude way of looking at it. And I know the guidelines now have 4 different drugs that look evenly weighted, but really this is kind of how I'm looking at it now. And then insulin right away if they have very high blood sugars and you need to get control right away. But even then, you might, once you get control, you can then think about adding back GLP-1 or SGLT2 to use less insulin. So the bottom line is really thinking about using these drugs a lot earlier in our treatment as opposed to, I've tried everything, maybe I should try one of these new drugs. Now it's like, no, I think this is right up there. The other interesting thing is, I think Earl quoted, I think a 0.7 to 0.9%, I think A1C reduction, but anecdotally, I'm seeing a lot bigger effects in some patients. And so patients where I thought we'd be heading right to insulin afterward, honestly, some of them I'm not. It's just pretty amazing. Also using a lot less of the other orals now as well. Which ones are we using? And this is mostly empagliflozin, and I'm not saying that's the right thing necessarily. Again, we had some concerns about canagliflozin because of the amputation issues before. So that was one reason, and mainly it's insurance coverage. So we've learned how to prescribe this. It's very easy dosing, and a lot of insurers are now carrying it as before they weren't. The GFR limits are doable for a lot of our patients, and I was interested to hear what Ian was saying about maybe we can push that lower. I would love to use this in lower GFR, but I don't want to get in trouble with our nephrology colleagues, with all of you. And then again, very excited because there's good outcomes for this drug for multiple different areas. So a lot of empagliflozin is what I'm seeing right now is the bottom line. Main questions I have is will it displace metformin as first line? I think that's an interesting question. I'm not doing that yet. I'm still starting with metformin. And then is this going to be used as a primary cardiovascular or chronic kidney disease drug, as was mentioned, even in patients without diabetes? I'm starting to think of this as just a really good diuretic, right? With hypertension, chronic kidney disease, and heart failure benefits, right? And keep in mind, like I said, with the diabetes drugs, a lot of these other cardiovascular drugs have huge downsides also, right? Thiazides, I can't tell you how many side effects I've seen from thiazides. So one question is, if they're comparable and you can't use both drugs, would this actually replace a thiazide or replace an ACE inhibitor in certain patients? So that I think is an open question that I'd be interested in hearing about. So again, just to summarize the evolution for us, really, and again, this is more our clinic, I can't speak to Harborview or the VA or the country, right? Is just earlier use in patients with diabetes, mainly weighed by the microvascular and macrovascular endpoints, coverage and ease of use as an oral drug. Still some worry about DKA, rare side effects, and really interested in the kind of future growing indications. And we can talk more about the communication issues in the discussion. So thank you.
Thank you, Dr. Wong. I just want to move on to our last panelist. We're running a little behind, but I think this has been great to have everyone's perspective. So I want to introduce Dr. Caroline Pitney. Dr. Pitney is Senior Clinical Lead and a Medical Specialties Ambulatory Clinical Pharmacist at the Harborview Medical Specialties Clinic. She's a clinical instructor at the University of Washington School of Pharmacy, and I know from personal experience that she works tirelessly for the care of all of our mutual patients. So Caroline, do you want to share your screen, or do you want me to put it up? You're muted also.
Thanks. Are you able to see my screen?
Yep, looks good.
Okay. Hi, my name is Caroline, and today I was asked to present on the clinical pharmacist perspective on SGLT2 inhibitors. So clinical pharmacists can practice collaboratively with providers under something called collaborative drug therapy agreements across UW Medicine. Pharmacists can initiate therapies, dose adjust medications, and they can also order labs for monitoring patients on therapy. Pharmacists practice in many ambulatory settings, including nephrology, endocrinology, cardiology, and primary care. Pharmacists could be an asset to help providers starting patients on SGLT2 inhibitors when initiating treatment with the counseling, as well as the initial monitoring and ongoing follow-up. Pharmacists could also help with concomitant empiric dose adjustments of other medications when appropriate for patients that are starting on SGLT2s. Some of the key benefits that you might want to cover with your patient when starting a patient on an SGLT2 include the reduction in major cardiovascular events and death, reductions in hospitalization for heart failure, and benefits in slowing the progression of chronic kidney disease. Patients may also appreciate the possible improvements in blood pressure and weight loss. I still think it's important to counsel patients about the potential risks of treatment with SGLT2 inhibitors. I want to point out that in the randomized controlled trials compared to placebo, the only statistically significant adverse effects seen with SGLT2 inhibitor treated patients were for genital mycotic infections, potential volume depletion with AKI, UTIs, a low but significantly higher incidence of euglycemic DKA, And as we've already discussed, there was a signal in the Canvas studies for increased amputation and potential fractures with canagliflozin, although this was removed as a boxed warning in August of 2020. Post-marketing reports of foreigners gangrene associated with SGLT2s led to the inclusion of this information in the prescribing information. But further meta-analysis and case control studies have shown that SGLT2 inhibitors, in fact, are not seen to cause higher rates of UTIs, urosepsis, gangrene, or AKIs compared to placebo or other glucose-lowering therapies. I've included some counseling considerations here in this table to have as a reference, and these counseling points are what are typically recommended in the medication package inserts for SGLT2 inhibitors. Also on the right, I've included the STOP DKA protocol, which can be utilized for the management of patients that present with symptoms of euglycemic DKA. This slide provides a reminder to consider preemptive dose reductions in things like loop diuretics and thiazide diuretics before initiating patients on SGLT2 inhibitors, especially in patients with low systolic blood pressure or patients that are at risk of volume depletion. In patients with an A1C less than or equal to 8.5% or well-controlled diabetes, you may also need to consider empiric dose reductions in anti-diabetic medications like insulin or sulfonylureas to reduce the risk of hypoglycemia. Consider monitoring patients for their blood pressure, their weight, their volume status, their renal function, serum electrolytes, and for any side effects within 2 weeks of starting patients on therapy. Then monitoring thereafter can be adjusted as clinically appropriate. When considering which agent to prescribe, think about the current clinical evidence from trials to support your decision-making. All the SGLT2 inhibitors show benefit in type 2 diabetes and for reduction in heart failure hospitalizations. Canagliflozin, dapagliflozin, and empagliflozin show benefit for reduction in CKD outcomes. To date, only canagliflozin and empagliflozin have shown reduction in MACE, which was largely driven by a reduction in cardiovascular death. This slide illustrates the cost of a 30-day supply of these various agents, and you can see that the cost ranges anywhere from $543 to $622 per month. The table also indicates if the drug manufacturers provide a copay card to bring down out-of-pocket costs for patients with private or commercial insurance. Mind you, these copay cards cannot be used with Medicare plans. I've also provided links to websites for patient assistance programs for patients that are uninsured. Also listed here are the most common Medicaid plans in Washington State, which have the preferred agents canagliflozin, dapagliflozin, and empagliflozin, as well as which agents are non-formulary. In addition, a few plans may still have quantity limitations on empagliflozin. Some questions that remain from the pharmacy perspective are, could pharmacists help with SGLT2 treatment initiation, counseling, dose titration, monitoring, and follow-up? SGLT2s are often covered, but one agent may be preferred by an insurance plan over another, and sometimes insurance may require prior authorization. Patients may also have high copays and out-of-pocket costs with therapy, so how should these issues be handled or communicated? When dose adjustments are needed for concomitant medications when starting an SGLT2 inhibitor, should consultation with the other providers managing these other medications occur prior to or at the point of prescribing the SGLT2? And should the patient monitoring and follow-up fall strictly on the prescribing provider and clinical team, or could the management and monitoring and follow-up be shared across disciplines? These next two tables are strictly here for your reference, and these slides will be shared after this presentation today, but I've included the current doses, dose adjustments, FDA-approved indications, and evidence for use for these agents, as well as the adverse effects and side effects. Thank you very much, and these are my references.
Thank you so much, Caroline. So maybe we'll stop the screen share. All right. So thank you so much to all the panelists. We're running a little behind, but we still have 15-20 minutes for a discussion. There's been a robust discussion already in the chat, but I wanted to open it up to some verbal discussion as well. And just in terms of looking at some of the key thematic areas and questions that people have in the chat, I think the first thing perhaps that I'll bring up is this sort of communication perspective and prescribing and communication between providers, just in terms of the real practical way to go about this. So I'm curious if some of the panelists have thoughts about that. Who should be prescribing these? Who should be responsible for following up labs, adjusting other medications, diuretics, other anti-diabetic agents? So I don't know if any of the panelists want to take a stab at least their perspective on that.
If I could just mention, I wrote this in the chat. Yeah, I am totally cool if you guys start these meds, but they're never urgent, right? It's never urgent to start one of these. So I think just communicate with us. And as I wrote in the chat, you know, we get like 1 million Epic messages. So if you CC the chart and just put a little note, hey, what do you think of this? It's possible I might miss it. So just email us or send us another staff message and we should discuss.
Yeah. Yeah. And I'm also fine with anyone doing it. I mean, my big thing, like in the one case, actually, there have been 2 cases of patients of mine where they were started on type 1s, and in neither time did the cardiologist know it was a type 1. They see diabetes and it's just type 2 diabetes, and that's not necessarily the case. I think the issue is for those patients who are on sulfonylureas or are on insulin. I sort of think that for most of those patients, the primary care physician who is usually writing for those drugs, or if they do have an endocrinologist, that communication should be made. It's actually quite easy to do that with UW medicine docs, whether in the neighborhood clinics or not, with Epic. It's more challenging for patients who are not in the UW system with docs that you don't know. I think the other big issue is if a cardiologist is writing for the drug and there is a side effect, an infectious side effect, for example, who is going to take care of that? You know, I just think that there needs to be much more communication than we've had because this drug is now being used for so many different things.
I can share my strategy and perspective as the cardiologist. I've kind of focused on the simple, quote, simple diabetic patient who's just on metformin and definite that I know they have type 2 diabetes. I write the prescription. I also communicate either through Epic or with an email or a phone message to the patient's primary care doctor or endocrinologist that I've written the prescription. But I ask the patient to wait and not start the medication until they've confirmed that their other members of their medical team are aware that I've written for it. But I find that if I have at least provided the prescription and sent it to their pharmacy, it's more likely that they'll start it than when I just put in my consult note, consider SGLT2 inhibitor, because I find that when I do that, I know people are busy, they have other priorities with their medical visits, they may not get to it, it may not get prescribed.
I'm glad to hear Chris and Earl in particular say that they're fine with other specialties prescribing these drugs. I really think that all specialties represented in the call today need to know how to prescribe these drugs. Otherwise, they won't be implemented to people who need them. And really, they're no harder to prescribe than a RAS inhibitor, which internists, endocrinologists, cardiologists all prescribe anyway. It's just a question of knowing, particularly the side effects, and being able to identify when there may be a complication or an issue, like hypoglycemia, not prescribing for type 1 diabetes. I think the follow-up is more tricky. And personally, I think if you prescribe the drug, you need to ensure some sort of follow-up. There's an individual responsibility, but I also liked Caroline's comment or suggestion that maybe there's a group responsibility too. This is very VA, and if Alec prescribes an SGLT2 inhibitor, I happen to see the patient 2 months later, and they're getting frequent hypoglycemia for whatever reason, I think I should be able to recognize that too.
Man, I had a question related to that, and I don't know how many other providers are involved in what we have at the VA, these non-visit consults, where we never see the patient, and we may only have one communication with the primary provider. And I'm wondering if we make a recommendation for an SGLT2 inhibitor, is there a reference or a key amount of information we should be providing to the primary care provider, sometimes in a multi-state region, to give them the key information that they may not be up on? I mean, also true for any recommendation for a primary provider to start the medicine, since it's new.
Maybe I'll turn that question to Dr. Wong. I mean, when you're getting recommendations from specialists about these and other medications, I mean, what is most helpful in receiving that recommendation?
Good question. I mean, those of us here are pretty familiar with it now, but you would want to be really exact. Which drug, what dose do you start? When do you see them back? You know, do you start 10 milligrams, then you go to 25? If they're on other hypoglycemic agents, you should reduce them. You want to be, if they don't have familiarity with that, you want to give them as much detail as you possibly can. But the patient does need to come back and have a discussion. You know, I don't think this is something that really should just be thrown in over the phone or in an e-care message, because there are side effects. You have to tell them about the GU infections and have to explain somehow what DKA is, right? So you do have to have that conversation. So I think if it's a consult where the patient's an asynchronous consult where the patient's not there, that PCP will need to bring the patient back and talk to them about it before they prescribe it. But that's just kind of my bias. I'm not sure how it works at the VA.
If I can just make one more comment to Chris's comment, and that's the number of people that we see in our clinic who are classified as type 2 and they're on insulin and metformin, and they are making no C-peptide. And in fact, we saw one a few weeks ago who had a pancreatectomy. He had pancreatic diabetes, and so he makes no insulin. And so I think that since 50% of type 1 diabetes is now, we know, diagnosed in adulthood, I think this is a great opportunity for all of us to make sure, is this patient really a type 2 patient? Because there are a lot of people that are misdiagnosed.
So there have been some comments in the chat about EGFR thresholds. What are people's thoughts? You know, expected EGFR drops with initiation. How do you kind of reconcile that with guidelines around EGFR and SGLT2 inhibitors? Maybe I'll first ask Ian to comment a little bit on that, and then others in the audience, not only the panelists who have expertise, are welcome to join in as well.
Sure, happy to be brief here. So with EGFR drops, it is hemodynamic, it is reversible. It tends to be less than RAS inhibitors based on the trial data. There were just 2 publications in the last month, one from Credence and one from, I think, EMPA-REG, looking at within the treatment group about how drops associated with subsequent outcomes. It's not a rigorous approach to this, but it suggested that drops in the 10 to 30% range weren't associated with bad subsequent outcomes, but more than 30% were. It's weak data to support, I think, maintaining an SGLT2 inhibitor at least to a drop of less than 30% in EGFR. The ideal way to do that would be to have an active run-in, have everybody have an SGLT2 inhibitor and then characterize the drop and then randomize them, but that's never been done. The threshold, the early studies all had EGFR thresholds of 30 or higher, but we now have, I think, 4 studies with lower. DAPA-CKD at 25, DAPA heart failure, I think, was 25, SCORED was 25, and I think one of the heart failure studies was 20. So I think we're going to see that go down. EMPA kidney goes down to a threshold of 20. I don't think there's FDA approval for that 25 to 29 range for any drug yet. Caroline might know, but I think it's reasonable to start thinking about it. There are no safety signals there. It's just a question of lack of data.
So Ian, do you recommend, we have a lot of patients where EGFR is not very stable, right? It's 35, 29, it keeps going up and down, and we will be very tempted to use these. Do you recommend we check with nephrology first, or what's your thought on that?
I think you need to check with nephrology. I had a patient on Tuesday whose EGFR had been 27, and I rechecked it. It was 32, and so I started him on an SGLT2 inhibitor before it went back down below 30.
So I'm not the only one who does that. I feel a little better.
There have been some questions in the chat about more questions about coverage for these drugs sort of in real life versus in theory. Dr. Wong, I think you had written some comments. I don't know if you want to elaborate a little bit about your experience here locally versus nationally, for example.
Yeah, I think Caroline had a good slide showing that Medicaid is even covering these. So, and before that was definitely not the case. So it's very encouraging. And then sometimes I've had to do prior auths with private carriers, and usually it's like, have they tried metformin? I say yes, and then, but they're not adequately controlled or they can't tolerate it. So it's very interesting. The prior auths are not about, oh, do they have cardiovascular disease and do they have another indication? They're entirely about, is it, you know, in the diabetes pathway? So sometimes you have to do some paperwork, but it's a lot easier than it used to be. And then there's some patients who just can't, and we're stuck with the other drugs.
So there have been some questions in the chat about these agents in patients with heart failure with preserved ejection fraction compared to, you know, most of the studies being heart failure with reduced ejection fraction. Alec, I don't know if you want to comment a little bit on that or whether there's more data coming out and what your practice is.
Yeah, there are dedicated HFpEF trials, randomized trials that are currently being ran. The sotagliflozin trial, which was just published in New England Journal this week, and I haven't had a time to dive into it deeply, but that trial did include about 750 patients with HFpEF, and the benefits seen in that subgroup were similar. Of course, that's a subgroup analysis, so the dedicated HFpEF trials, we'll have to wait for those, but I think people are hopeful that the drug will have similar benefits. And that makes sense if all of the other mechanisms I mentioned in my first slide hold true with improved myocardial energetics, improved afterload reduction, and all these other effects beyond just the diuretic and glucose lowering effect.
This also from the cardiology perspective, I'll just note Dr. Cooper is here and has put a comment in the chat. She feels that several patients have had complications, I think with respect to volume, and that she feels like these patients with heart failure with reduced ejection fraction may really need to be followed closely after initiation. Stephanie, if you're there and have audio, do you want to just elaborate a little bit?
Sure. Actually, some of the pharmacists in clinic are collating patients who've had adverse events, but I've had patients both that we've started and that other practitioners have started, either nephrology or primary care, who've come back in a couple of weeks later with a marked drop in their GFR, hyperkalemia. I've seen hyponatremia. And then also these patients seem to lose their appetite. You guys probably know that better than me. And so I've had elderly patients with HFrEF, for instance, who lose a lot of weight, which is not necessarily in their best interest, especially if we don't know about it. And then definitely hypovolemia. So I personally feel like these patients need to be seen within a week. And if I prescribe it, that's not an issue. But if somebody else prescribes it and they say follow up in a month or follow up in 3 months, I would rather get the communication that you guys have talked about and be happy to see them in clinic myself within a week.
Yeah, and Ian is making the comment here that he agrees with you, Stephanie. We need to be concerned about higher adverse event rates in real life, compared to perhaps what we're seeing in some of the clinical trials.
Yeah, I'd add, we saw that, the RALS trial, aldosterone blockade and heart failure, there was a really profound mortality reduction in that trial. And then it was noted that after that, there was an increase in the community of patients experiencing sudden death because cardiologists and providers were enthusiastically starting aldosterone blockers, and then patients were getting hyperkalemia and dying suddenly. So yeah, we of course have to watch these patients very closely, as Stephanie points out, and try and, I guess, replicate what's done in clinical trials with frequent lab draws and patient visits.
So we're really near the end of the hour here. I just want to see if any of the panelists have any final comments as we end the discussion here.
I appreciate the discussion. I wish we had more time. It's really fabulous to have the guest speakers here and break out of our nephrology world, and lots of points of agreement here on how to get these patients appropriately to drugs. So thank you.
Yeah, it seems like just from my perspective as a non-panelist, it seems like the major point that I'm hearing here is the importance of good communication between providers in the prescription of these medications, and just open communication about follow-up intervals and follow-up regarding these patients. So it's, I think, an important message that more communication is always better. So I really want to thank our panelists here. So Dr. Boer, Dr. Hirsch, Dr. Moorman, Dr. Wong, and Dr. Pitney for putting in the time and effort to be here. Thank you so much. I'll note that we had Nephrology Grand Rounds record of participants of 103 at one point during the discussion. So that's great.